Frequently asked questions about surgical treatments for anal fistula. 1. What is an anal fistula, and how are they generally classified? An anal fistula is an abnormal connection between the anal canal and the skin near the anus. This can lead to symptoms such as pain, swelling, bleeding, and discharge of pus. Anal fistulae are commonly categorized based on their relationship to the external anal sphincter, AS. Simple fistulae include intersphincteric or low transsphincteric fistulae that cross less than 30% of the AS. Complex fistulae involve more of the AS, greater than 30%, are suprasphincteric, extrasphincteric, horseshoe-shaped, have secondary tracts, are anterior in women, or are associated with conditions like inflammatory bowel disease, radiation, malignancy, pre-existing fecal incontinence, or chronic diarrhea. 2. What is the primary aim of surgical treatment for anal fistula? The main goals of surgical treatment for anal fistulas are to achieve complete healing of the fistula and to preserve bowel continence, meaning the ability to control bowel movements. Finding a treatment that effectively balances these two outcomes has been a challenge in the management of this condition. 3. According to the network meta-analysis, is there one surgical treatment that is definitively better than others for healing anal fistulae? The network meta-analysis, which compared the efficacy of various surgical treatments, found that there was insufficient evidence from randomized controlled trials, RCTs, to recommend one treatment over another for successfully healing both simple and complex anal fistulae in the short term, 6 months or less postoperatively, or the long term, more than 6 months postoperatively. 4. Which surgical treatment appears to be the best for minimizing the risk of bowel incontinence after anal fistula surgery? The ligation of the intersphincteric fistula tract, LIFT, procedure was identified as the treatment most likely to minimize bowel incontinence in both simple and complex anal fistulas, based on the available evidence. This finding held true even when all treatments, including those studied in only one trial, were considered in sensitivity analyses. 5. What is the lift procedure and for which types of fistulae is it typically indicated? The lift procedure involves identifying and ligating, tying off, the fistula tract in the intersphincteric space, which is the area between the internal and external anal sphincter muscles. It is primarily indicated for transsphincteric fistulae, where the fistula tract passes through this space. However, the study suggests it may also be beneficial for continence in other types of fistulae. 6. Were there any differences observed between treatments regarding hospital length of stay or overall postoperative complications? The analysis of hospital length of stay in patients with simple anal fistula showed no significant difference between fistulotomy with marsupialization and standard fistulotomy. For complex anal fistula, hospital length of stay could not be reliably evaluated as no single treatment was assessed in more than one trial. Similarly, overall postoperative complication rates in the included studies did not show significant differences between the compared treatments for either simple or complex anal fistula. 7. What limitations or challenges were encountered in conducting this network meta-analysis? Several limitations were noted, including the fact that many newer treatment techniques have only been studied in a single trial with a small number of patients, limiting the ability to draw firm conclusions about their effectiveness. There was also significant heterogeneity in how anal fistulae were defined and classified across different studies, and variability in how healing and incontinence were measured and reported. The follow-up periods in the studies also varied, particularly for assessing long-term success. 8. What are the implications of these findings for surgeons and future research? The findings suggest that while lift appears promising for preserving bowel continence, more high-quality research is needed to determine the most effective surgical treatments for healing anal fistulae. Future studies should aim for standardized preoperative investigations and classification systems for anal fistulas, consistent reporting of outcomes using agreed definitions, longer follow-up periods, and larger sample sizes, particularly for novel techniques. This will help surgeons to better counsel patients and choose the most appropriate treatment based on the individual characteristics of their fistula.